Professor, for the invitation and very nicely to have you here. And I will share with you this presentation. Can you hear the screen now? Is that okay?
We don't see the screen yet. Can
Not
you?
yet.
Not yet. Click on the share screen.
Currently,
Yeah,
it's okay.
yeah, it's coming up.
Okay.
Just go for a full screen.
Yes. Okay.
Yeah,
Okay.
yeah.
My topic here is very common in the trauma, and but sometimes it's lead very bad consequence. Is corneal microperforation, because many professors have shared with very severe trauma, and we always share our experience on the very severe one. But sometimes corneal perforation can derive from a variety of disorders, but they may lead a very devastating ocular consequence. After infection and traumatic inflammatory eye perforations are the most frequent etiology. And we can make the diagnosis very easy because they have the leakage, and a CTO test can be helpful. And we can clearly see the CTO test for positive for the diagnosis. But for some cases, there's have the if the micro perforation is not very big, it's very small, and with the intraocular pressure decrease, and sometimes it's sealed. So you can't see the CTO test positive, but you can push on the eyeballs if you give some pressure, and the CTO test will be again for the positive. And sometimes with the severe of corneal lesions, like the corneal lesion is white, so it's difficult to tell it's have the micro perforation or not. For those things, we need to pay attention to. And the key to management is of the two part is treat the cause or reconstitute the global. And the causes for the corneal perforation include for according to the AAO guideline, and it's about those size can cause by trauma. It's also very common, and also keratitis. We have many infections and non-infections. Mostly micro perforation happens in neutrophilic keratitis, and also many infectious disease, and also some autoimmune disease. And for some we need to pay attention to. In this meeting, I want to emphasize is less common that the anterior chamber is not shallow, and it seems it's nothing special. It's just the thinning of the cornea, but there is a big pigment on the wood. It's just a little sign, but it's also have the evidence that maybe they have a macro perforation, because the brown pigment from the iris in the wood itself sometimes it exits the fluid from the eye, and then the iris the pigment is attached to the perforation, and plug in the hole. So it's when you check the patients, and it seems the cornea is fine, but they have some a little bit pigment. So it's very special. Pay attention to it's sometimes they already have the microperforation, and they maybe the unstable, but sometimes it's stable. So you need to judge, and also have some infectious disease, and it's just as I said, it's have the white or swollen cornea, and it's hard to tell. It looks like the cornea is not very thin, but actually they have the micro perforation already. And the brown spot is cornea perforation in the center of the cornea ulcer, maybe hard to detect. And one clue can be pigmentation in the area of the perforation, which may be left behind after the iris plug in the hole. But it's not a staphyloma. I think it's just a little bit, so that we need to pay attention to. And for the treatment, is optimizing the healing while taking care of the underlying causes. So the meningium and the perforation, we have the medical heart is treated under course like some autoimmune disease, because there's always have the melting like Stroll syndrome and SSE or rheumatic disease. They sometimes have the autoimmune melting on the cornea, and if you can't treat the system systematically, it can't hold the cornea to heal. And sometimes we use the proteinase inhibitors to oral take those medications and to stop to prevent the collagen from melting. And also antibiotics are very important for topical and systemic. I'll show behind. And also have the aqueous humor suppressor is important. It's a patient for the Stroll syndrome, but it's a severe one, and he have the double eye. For both eye have the corneal perforation, and with the cornea with the anterior chamber is disappear, but he has very bad systemically, so we can't do the surgery, and he had treat in the other department first, and then after 10 days the system may become stable, but we see the perforation has been sealed, and I think it's because we gave some medications and with the systematic control, and the heal has, but we can still see a little bit pigmentation. But if we see the OCT from here, we can say the stroma a little bit regeneration is over 10 days after the systematic treatment. And for those patients, they have the perforation, but if we treat nightly, they can heal they have healed spontaneously and without the surgery, and the stroma has a little bit respawn. You can see they can with times the stroma can regenerate a little bit. So it's prevent from the surgical. But so treat the cause is very important for the autoimmune treatment, and oral steroids or very rheumatologist general treatment is needed.
Can you sum up your talk, please, Dr. Feng?
Sorry?
Can you sum up your talk, please? Because we are short of time.
Okay. And promoting the cornea healing and observation. For some, the important thing is we give the operation. If we give the observation, we need to pay attention for the daily, for the first few days, and begin to leak later. And this another patients, they had a very small leakage, and it seems fine, so it's give the observation, but a week later, he has a very severe infection, and with the cornea transplant, you can see it's very bad results in the follow-up. And what's seen in during the surgery, you can see from it seems a little bit infection, but it's actually grow into the eyeball, and it's all behind the iris. So it's the whole endophthalmitis, but it's just from a very micro perforation. So for those patients have the systemic, they use the topical immunosuppressive on the eye. Those patients we need to pay attention to, need to a very close follow-up. Otherwise, they can't heal, but they have caused a very bad endophthalmitis, and the high risk, and for another traumatic, the high risk of leak and gaps. These patients, if we use surgical treatment, we can use anatomic membrane graft for the irregular patterns. We use the membrane to multi-layer and to suture, and they can heal the micro. It's very quickly and very good management. And sometimes for the iris plug-in, we can use the to glow things, and for a long time we need to run all this. I just make it quick because it's same times. For small perforations, we can use the scleral flap or the conjunctive flaps also, because it can get the vessels in, and it's prevent from the infections also. And for large perforations, sometimes if you can rule out the infections, we can use the keratopathy PKP to larger piece graft. And laminar transplant is always recommended for corneal surgeon because it's very good results, much better than the penetrating keratopathy. And those patients will use double layer technique to heal the micro. We don't seal them, we just use a small piece to seal the micro perforation, and then we use a small, bigger piece for the double layer transplant. And this will be a huge, very good visual acuity, and to keep the endothelium stay there. And surgical strategy for laminar transplantation is set the tissue and central cornea, keep it clear. Is to gain the very good vision acuity. But be careful of the trauma patients. It's not very stable. This is the patients have a trauma and it's almost over half a year, and his vision acuity is not very bad. It's 0.3, and but he has a complaint of sudden vision loss and for 1 month. And you see it's a little bit fine, and OCT source is not very thin. But if we saw the ultrasound, because the vision acuity is light perception, and if we see the eyeball, we can see a very a choroid hemorrhage in the eyeball. So this because I think the small wound, it's have the thinning, and they have the microperforation, and then cause the hypotony cause the later choroid hemorrhage. And then we do.
Sorry, we are running out of time. Can you wrap it in 1 minute, please? Yeah.
Yes, it's almost done. So we get the hemorrhage, so choroidal in the equator one, so and we can see the hemorrhage, and then punch the cornea and use a very small piece and to get the clean cornea, and to suture the cornea. And then we only use this one small wound to get all the hemorrhage out. So it's a typical technique. Okay. So these patients have very good results. We can see this is the corneal patch, and all the is a very acuity is 20/50. So it's have very good results if you find the reason and get the treatment while this. So the summary is we have the surgical treatment for small micro perforations to get the glow. And most of them we can use the glow, and also have some conjunctive flap for the peripheral one, or have the infection suspected. Amniotic memory and transplantation is sometimes in some cases is needed. So be careful for the observation patients. So otherwise they maybe have the choroidal hemorrhage and also the severe endophthalmitis. Okay, thank you for your attention.
Thank you, Dr.